Dr. David Nash, thank you for joining Business of Healthcare again. AHEOR, what is that?
Yeah, what is that? So that's our jargon for health economics and outcomes research. Matt, this is a global field. Every year we go to an international meeting called ISPOR, I-S-P-O-R, International Society for Pharmacoeconomics and Outcomes Research. You're not allowed to show up unless you can spell pharmacoeconomics. But listen, HEOR is a really important global scholarly field. We've been involved in HEOR in the last 25 years of my tenure here at Jefferson University. It predates the creation of our College of Population Health. We have the largest academic medical center-based training program, a postdoctoral training program in HEOR any place in the country. We have over 50 graduates of this program virtually in every major pharma company worldwide. It's an incredible part of our legacy. So HEOR is the science of cost-benefit analysis, cost-effectiveness analysis, comparative effectiveness. We put all of that CEA, comparative effectiveness, under the umbrella of HEOR. And here's why it's so darn important. Look, we've been tracking the cost of healthcare and the cost of drugs within that. When we started our HEOR fellowship, drug costs were 3, 5, 7 cents on every dollar spent for healthcare. Well, here we are now in the modern era, we're talking 15, 20 cents of every dollar spent on healthcare now going towards the drug costs. With precision medicine, with genetic therapy, we're talking about now, various medications, $400,000 per dose per eye. So HEOR, more important than ever before, we want to understand what are we getting for the investment we're making in these fantastic new products. Look, we've cured certain types of hepatitis, right, with a drug. Broke the budget of every Medicaid plan in the country when these drugs came out. So HEOR is the science of analyzing these amazing trends both in drug development, drug deployment, and trying to understand what should we put on the formulary and why. I mean, in its essence, that's what it's all about.
Dr. David Nash is the founding dean of the Jefferson College of Population Health, the nation's first institution dedicated to population health management and research. His illustrious career is overwhelming to summarize. Board and oversight roles with health systems, influential organizations such as the National Quality Foundation, and for-profit enterprise such as Humana and Arsenal Capital Partners. Nash has authored over 100 peer-reviewed articles and edited 23 books. He earned his undergraduate degree from Vassar College, medical degree from the University of Rochester, MBA in Health Administration from the Wharton School, and was a Robert Wood Johnson Foundation clinical scholar. He advocates population health interventions to keep people healthy and avoid chronic disease, such as diabetes, heart disease, and obesity, or as he likes to say, shut off the faucet instead of mopping up the floor. There's almost an ethical element to this. If I spend $1 on the prevention of hepatitis versus $1 or $4 on the curing, how does that fit into the academic experience?
So HEOR experts are the ones who help provide policymakers with the evidence to make those kinds of decisions. And at the doctoral level, our HEOR folks are involved in the policy making as well. But we see health economics and outcomes research is a major global field. We're very proud of our history here, and we have domestically the leading online asynchronous master's degree in HEOR in the United States, rivaled only by some overseas programs, most particularly in the United Kingdom. So we are looked at as one of the major leaders in HEOR education, both in our postdoctoral in-house program and our online degree program in AHEOR, which is really, really well regarded.
The online degree program being a master's level program.
Yes.
And what's the profile of a student in that program?
Yeah, great question. So it's a little counterintuitive. The typical student already has a doctorate in pharmacy, or a master's degree in pharmaceutical science and medicinal chemistry. So the typical person coming to us is already pretty highly educated, but they don't get the HEOR piece in pharmacy school at the master's level. They may have an introductory course. So the typical student who comes to us online interested in HEOR is working in industry or related to pharma, information technology, biotech development, and they want to have the skill set to compare and contrast outcomes and to create the evidence for policymakers to make a good decision.
That relates to another program that you operate, which is your population health intelligence.
Yes, they're closely related, so let me try to define the differences. So HEOR, been around for decades, really important, helps build the evidence case for what's on the formulary, what should we pay for, what's the priority list, and is a well-established field unto itself. Now, recently, we've created another degree program in our College of Population Health. We call it Population Health Intelligence. It's a great term. We actually had it trademarked. So, look, there's a lot of jargon out there: population health analytics, predictive analytics, artificial intelligence, augmented intelligence. I could use some of that. But population health intelligence in its essence is this. We got all this data. What's the information we're gleaning? What are the insights from the data? So, for example, Pop Health Intelligence says, look, your zip code is more important than your genetic code to predict your lifespan. In fact, if I know your zip code and your credit score are probably more important than my knowing your blood pressure and your cholesterol and your hemoglobin A1C. And I know some of our listeners are thinking, what is that about? But look, Pop Health Intelligence draws on data from different sectors, not all clinical, and makes inferences backed by the evidence about clinical conditions. It's really very, very powerful. So Pop Health Intelligence, our new program, we're not teaching people how to code. We're teaching folks how to glean information from the overwhelming amount of data that's available now in the system.
And those students, are they similar in profile to your HEOR students?
Typically not.
Okay.
Typically not. So again, we have a master's degree in health economics and outcomes research, all online, asynchronous, probably the best one domestically anyway. And then our new program, Pop Health Intelligence, again, we're not training folks to write code. You're not going to become a head of information technology with this degree. What you will do is you'll be a vital, key, emerging leader to make sense out of all of the incoming data and glean information and make inferences about, well, who might be readmitted? Who might need intensive case management? What are the social factors that are influencing these patients from these 6 zip codes, and why do we keep seeing them in our emergency room? That's population health intelligence.
You've surrounded yourself in creating the school and creating the program. You've surrounded yourself with research in these areas that you're fascinated by.
Yes.
You've also, if I recall correctly, testified before Congress.
Periodically.
If you could get the U.S. Congress to put in place one policy that would dramatically improve the effectiveness of our healthcare system, what would that policy be?
Wow. Well, look, I've been on this gig for nearly 30 years. Lots of smart people out there have tried to change healthcare. You know, one thing I tell our faculty and staff, in confusion, there's opportunity, right? So that's the glass is half full all the time. Well, that's a great question, Matt. My answer would be, look, we know when you change economic incentives, you change clinical decision making. This is the key issue for me. So I'm all about Center for Medicare and Medicaid Innovation and bundled payment, global fee, capitation, whatever you want to call it. I'm all in support of let's align the economic incentives to use resources in a more appropriate, evidence-based way to achieve a better, safer outcome at a lower cost. So to me, the answer to the riddle is bundled payment, global fee, capitation, whatever you want to call that, but change how we're paid and we will change clinical behavior. No doubt about it.
And so HEOR and population health intelligence
figure right
together.
into that. Right. Now, it's not the total story,
Sure.
but they are the core components of understanding. So let's play that through. So I'm a major academic medical center delivery system leader, and I'm in a bundled payment program for sepsis and congestive heart failure, let's just say, because that's Jefferson is participating in these two. So what am I going to need to know? Well, holy mackerel, I'm going to need to know what are my true costs? We really have no idea. What are the social determinants that are driving people to in heart failure? What are the predictors of people who might get sepsis? What is the information technology needs? And then what's the clinical course all about? And then where are they going to go when they're out of the hospital? So we have a lot of data. We need better information. Hence, HEOR, population health intelligence, bundled payment, all fits together beautifully.
Fascinating. Dr. Nash, thank you so much
Thank
for
you.
sharing this with the business of healthcare and our audience.
Thanks again.